everybody. I'm Professor Usha Dutta. I'm from the Department of Gastroenterology at PGIMER Chandigarh, which is a premier institute in northern India. Today we have a special guest with us, Professor K.L. Goh, who is from the University of Malaya in Malaysia, Kuala Lumpur. He is a leading figure in the Asia Pacific region with his seminal work on H.Pylori and other luminal diseases. In Malaysia, he is now the editor of the Journal of Gastroenterology Hepatology, and he has taken the journal to very high levels. It's my pleasure to introduce Professor Goh here to the audience. Professor Goh,
thank you, Professor Dutta. It's a pleasure for me to come to Calcutta for the APDWF.
Professor Goh, we have an issue with H. pylori in our country because we see a lot of H. pylori positive patients and we have a lot of dyspepsia. With the new Rome 4 as well as the Maastricht 5 consensus, what are your views? Should we be investigating all our patients of dyspepsia for H. pylori, and if you see it, should we be treating it, and what regime should we use?
Dyspepsia is a very broad disease that has many etiologies. When you look for H. pylori in dyspepsia patients, you are able to group patients that have a known cause, so to speak. And in that group of patients with H. pylori, and you treat them, a big proportion of them will improve their symptoms of dyspepsia. So I would think that dyspeptic patients should be screened and tested for H. pylori, and if positive, they should be treated. For that matter, any cases, my opinion, I'm very pro H. pylori eradication. Any patient that's detected to have H. pylori positive by any diagnostic test, as it stands at this point in time, should be recommended treatment eradication therapy.
So would you think that even if H. pylori serology is positive, we should be eradicating?
Serology is not as accurate as other tests because it is indirect. You're looking at the antibodies against the infection. So and it's not as sensitive and as specific to other tests, and it doesn't reflect the current H. pylori infection.
So you mean if you have an RUT positive, rhabdourious test positive, or a breath test positive, or a culture positive?
Yes, that would be more definitive for diagnosis of H. pylori, bearing in mind that these patients have not been on proton pump inhibitors or antibiotics for at least 2 weeks or 4 weeks.
That's a very important point you have made, that it's before you test for H. pylori, patients should be off antibiotics and PPI for minimum of 2 weeks. That's absolutely on the dot. I wanted to ask you about when you do an endoscopy, do you look for corpus gastritis, antral gastritis? Do you grade? What is the risk of cancer in these patients?
All these recommended regimens like Olga and Olgin. Generally, I would say, in truth, in clinical practice, I would, of course, look at the antrum and the body, but I don't grade them specifically, or shall I put formally, but I do make a note, and some patients, of course, have very severe gastritis and even changes of atrophy and even endoscopic metaplasia. I do take a note of that, but I don't routinely sort of categorize them in my routine clinical practice.
So you must be traveling to various centers all around the world. Do you find a difference in the Malaysian gut, the Indian gut, or the Western gut? Do they look different to you, the upper gut?
Yeah, generally they're all the same, I would say. It's very hard to distinguish. The only other thing is that that's a separate matter. Reflux esophagitis to me stands out quite a little bit different amongst Western patients and Asian patients. But in Malaysia we have many Indian patients and Chinese and Malay patients as well. So familiar with seeing Indian patients.
So do you see a lot of atrophy in the stomach in Malaysia and Indians?
Not really that much of atrophy in Indians. Maybe a little bit more in older Chinese. But that also, I don't think it is as high as reported from China itself.
Okay, so what's in your practice if you find H. pylori positive on a rhabdourious test? do you put them immediately on antibiotic therapy,
Yes.
or do you culture and look at their resistance and then put
I
them?
don't culture because culture is tedious, expensive, and many a time the lab cannot get a successful culture. So we base on what is known as our local
Resistance
resistance
patterns, yeah.
patterns, and I would treat the patient with a proton pump inhibitor, or nowadays with new acid suppressing drug, caps, with 1 or 2 antibiotics.
Okay.
And we normally like to use clarithromycin and amoxicillin. Clarithromycin we still use in Malaysia because the reported background resistance rate is so low. But we know that we need to monitor that closely because clarithromycin resistance rate is galloping along. It's increasing very quickly. We studied levofloxacin as well as a second-line rescue therapy many years ago, and we published it was good. But again, we have been told that levofloxacin resistance rate is rising. We have not formally reported it from Malaysia, but we think that that is also rising.
Yeah, there was a recent Asia Pacific consensus meta-analysis on the rising resistance to clarithromycin and to levofloxacin.
As well.
Yeah.
So in local practice, I have this preference for a high-dose dual therapy, and I often like to use PPIs with multiple dosing amoxicillin, and that has given us good results.
So do you use concomitant therapy? Do you use hybrid or sequential?
I know about them. I've used on individual cases, but I don't recommend it to my juniors, for instance, or to my department, because it's not easy to follow. Sequential, hybrid, to me they're a little bit complicated regimens. And
I, in my practice, prefer concomitant therapy, 4 drugs.
Right, 4 drugs,
Four
yes.
drug therapy.
I have used concomitant therapy in quite difficult cases, yes. But I find sequential therapy,
Is
hybrid,
confusing.
is a bit difficult to follow.
There's emerging data that maybe amoxiclav, that is amoxicillin with clavulanic acid, may be doing better than just amoxicillin alone. What are your views about it?
I've not had the opportunity to test amoxicillin clavulanic acid, so presumably it may do better, but I go for high dose amoxicillin.
Okay, that's
Multiple
1 gram?
dosing, yes.
1 gram twice
1
a day?
gram, no, 1 gram 4 times a day, 3 to 4 times a
4
day.
times a day?
Following the Japanese Furutas regimen, and many years ago the Germans, some German groups have tried that, and more recently, 2016, one Taiwanese group from NTU had also reported that in CGH. So it's sort of a personal preference that I used like a PPI with amoxicillin 1 gram 4 times a day.
That's a pretty high dose, because many of our patients don't manage to tolerate such high doses because they develop diarrhea.
Yeah, it's a compliance issue really. They have some diarrhea, but not a major issue in our. We've got the data, it's been collated, and we should write it up. But I can tell you up to 20-30% find that they forget to take 4 times a day, but side effects are usually tolerable. And we use amoxicillin tablets that are 1 gram. So you can't use 250 milligrams and then they have to take 4 tablets or 4 capsules. You take a 1 gram and then you take 4 times a day.
So you stop using metronidazole altogether?
Yeah, we almost never use metronidazole
And
nowadays.
tetracycline?
No, for some reason
We don't
never use tetracycline.
And do you get bismuth freely in your market there?
Bismuth again is not easy to get. So we have tested in our last trial for rescue therapy with PPIs and high-dose amoxicillin with bismuth. But bismuth is available in Malaysia, but not readily available. So
I find this very interesting and intriguing, I would say, that bismuth is such a cheap drug, so easy to manufacture. But for H. pylori, it can become a cornerstone in treatment because it has very low resistance.
No resistance,
Yes, so I don't know why we are not able to engage with the pharmaceutical companies to get more bismuth into the market.
I think there are other considerations when it comes to making drugs available from a commercial point of view, etc. So bismuth remains, I think, in Malaysia for sure, perhaps in India as well, not so readily available.
I have tried to now make it readily available in Chandigarh.
Okay.
So it's a question of, I think, just liaising with the pharmaceutical companies and saying that we need it, please keep it in the market.
That would be important, especially for resistant cases.
Yes, that is true. The other question I have for you, I read your paper on biofilms and how H. pylori, survives in a colony of biofilms in contrast to living alone. And very interestingly, the H. pylori sits on these stomata and it's just colonizes at those places. So what are your views about how we should handle vegetables before we eat them?
My personal view, after so many years, the mode of transmission is still not entirely clarified. And Barry Marshall still feels that it comes through water, etc. My personal feel is that it's a human-to-human contact. And I don't know whether through contaminated vegetables, whether it survives in the contaminated vegetables, so to speak, and whether that would be a mode of transmission. For H. pylori in particular, I'm not talking about other pathogens.
Because the other important mode of transmission is through an infected elder sibling, which is a very important route of transmission.
Within
families. So, do you have any message which we should tell our patients to reduce the transmission? Like Japan, Taiwan, they have all significantly reduced their transmission.
I think there was only there's one common denominator here. It's just rising affluence, better family hygiene, better personal hygiene. And without taking any deliberate steps, it seems to have brought the H. pylori prevalence down a lot.
The other question I have for you is with H. pylori treatment, when we have H. pylori treatment, there is an increase in obesity. There is a fear that it might reduce the infections, increase autoimmunity, increase obesity. So what are your views about that?
Atopy, allergic eczema and things like that. That has always been borne in mind. But as it stands now, I think in Asia Pacific, Helicobacter pylori is more a pathogen than commensal in inverted commas. And that's a difficult view, and very good people like Martin Blazer and all that, they have thought very far ahead, and they have regarded that Helicobacter pylori is an ancient bacteria and you should keep it, etc. But I think there may be truth in that, but for the moment I feel in Asia Pacific, with many parts having high rates of gastric cancer, that we should consider it still a pathogen and get rid of it.
It was wonderful talking to you. Thank you for your insights, which has come from a lot of research which you have done on your own, and we really appreciate your contribution to science in this area of H. pylori.
Thank you.
Thank you so much.
Pleasure, Asha.
Thank you.
Thank you.
Thank you.